So Stephen, from a managed care plan perspective, how could maybe with payment reform or pay for performance, maybe even meaningful use with technology, how do you foster these care team member to care team member relationships that maybe enhance and aid in the relationship with the patient? So I'll give you an example. A good friend of mine, Joe Moose, came up with this ideation of thinking about this. As typical prescription might be metformin 500 milligrams, take one tablet twice a day, number 60 with 5 refills. That's it. What if there was a prescription that said metformin 500 milligrams a day, take one BID, number 60 with 5 refills, patient's newly diagnosed, their hemoglobin A1C is 12.3.
A lot more information.
They don't like needles. They're scared of needles. And what we'd like for you to do is call and check and make sure they don't have stomach upset or anything going on wrong with the medication in the next 3 days. We'd like for you to make sure they get back to the office for their hemoglobin A1C within 3 months. And oh, by the way, the care manager's phone number and name is the following. What kind of a different relationship does that look like? And what is the role of the payer, the purchaser, the folks that are paying for this wonderful healthcare delivery system to foster those types of relationships?
So we're focused on paying for value over volume, as you kind of laid out there, Troy. That means that we're rewarding clinicians for outcomes. So for example, last year we had actually lower total cost of care for persons with diabetes and what we call our value-based programs, and improved outcomes. So at least as we're able to measure outcomes as imperfect, and I know that's a topic for some additional discussion, but hemoglobin A1C, getting your diabetic annual retina exam, getting your attention to nephropathy, the comprehensive diabetes measure. So that's really how we're working, is to reward those kinds of outcomes, both economic outcomes and clinical outcomes, and to harmonize those. Additionally, we're doing an increasing amount of clinical data exchange with our partners, so allowing for our claim data to be harmonized with EMR data and developing a health information exchange. So that's certainly another area where we're looking to improve the care process.
Right. So is there a role just from information that you know? So if you know who their primary care designated primary care provider is, or the care manager, does it make sense to share that with the pharmacy, for instance? Does it make sense to share care manager information with the practice? Does it make sense to have, for instance, shared metrics? What if different types of healthcare providers were held to the same types of metrics?
Yeah, absolutely.
Does that foster more of this team-based care?
Our pharmacy team increasingly working with clinical pharmacists in our health systems, so they are actually at the table simultaneously with physicians and nurses and administrators in terms of looking at how we are going to longitudinally improve our outcomes, our clinical outcomes, our economic outcomes, and our patient satisfaction or patient experience, so the triple aim of health. So those are the kinds of conversations that are going on, and I'm very happy to say increasingly pharmacists are at the table.
One of the challenges for the information system is that discharge gap. We are in a market with 2 dominant healthcare systems, a number of independent practices, and probably the majority of the patients in the city are still in independent practices, but getting communication and getting that discharge information, and this was changed for this reason, we sent the patient home with this prescription, is very difficult to obtain in a timely way. And that's very important part of good outcomes. And it would be very helpful if the payers paid attention to that and made sure that the information systems were translatable and that access was given to independent pharmacies and practices to see that.
In violent agreement with Richard, and again, notice of admission is something we've been doing for years. Notice of emergency department visit is something we're doing increasingly, and other kinds of relevant clinical information to crosswalk from one health system to another, from a health system to an independent physician, and a very important part of the work ahead.
And to add to that point, I think there's a lot of even data in how that's been very beneficial in a closed system. So I have the opportunity to work in a closed system where what you just described, it doesn't matter if you're the staff pharmacist, the clinical pharmacist, the attending, everyone has access to that patient if they consume their
This is
care
at the
within
VA.
the VA system, right? And so, we've had an electronic medical record since probably the late 1990s, where if the patient goes to the Phoenix VA or they go to the Boston VA, I can pull up labs, I can pull up their care plans. And so I think, and we've seen those other examples from, the Geisingers and the Kaisers of the world, where that closed system and that sharing of information is really, really beneficial, especially in a disease like this, where you have so many specialists that are touching that patient, right? And we know, just the cardiovascular burden of just diabetes, and, now more and more, folks are going to be working on that patient for any, specific reason. You mentioned eye exams, foot exams, and I think those are kind of tied to metrics, but one of the things that we're experiencing in our area is some of these drugs that are now having cardiovascular data. And so now we have our cardiology colleagues conversating with us, which previously hasn't happened. And so I'm glad you brought that question up, is because now this shared piece of literature has helped open up the doors, where I'll get a call from a cardiovascular colleague saying, hey, we know about the cardiovascular data, but we're unsure of how to prescribe this, diabetes medication. Can we work together in figuring out how we get this patient on it for this cardioprotective reasons? So
just one comment on that. I really appreciate and am at the altar of data. That said, is to paraphrase, culture eats technology for lunch. So if you don't have the kind of relationships that Trip described, if you don't have that trust that Richard has with his patients, and hopefully I have with mine, it all is for naught, because you can have all the wonderful data you want. If you don't establish rapport, trust, mutual respect, then it all goes out the window.